everyone. We're going to go ahead and get started. Welcome to NDD's webinar titled DLCO in Cardiology. We're so excited for everyone to join us today. February is actually American Heart Month as well as Go Red for Women. So we thought this would be a fitting topic to focus on today. My name is Jamie Burgess and I'm an RT with NDD.
And my name is Darren Fitzpatrick and I'm also an RT with NDD. Today we are happy to have Dr. Peter Zambito from Zambito Heart Center on the call with us. Dr. Zambito has been a friend of NDD for many years and is actively using the EZ1 Pro lab in his cardiology office. With the growing number of cardiologists adding PFT testing to their practice, we thought Dr. Zambito would be a great reference for us for our current and future customers. So thank you, Dr. Zambito, for jumping on.
So a little bit of housekeeping as always. We're actually going to have the question and answer box open on the right side of your screen. Feel free to type in your questions as they come up throughout the presentation. We do ask if you have any specific questions for Dr. Zambito, we will take a moment after our interview time with him to pause and so that he can address those questions. But then anything else that comes up, Darren and I will make sure that we check that box again at the end. And then also, there will be a post-webinar email sent out. It will have both of our contact information in there. And any questions that come up after the fact, you guys can always feel free to email us those questions. And there will also be a recording of this presentation.
Yeah, absolutely. Right.
So our objectives for today. First, we're so excited. We're going to hear from Dr. Peter Zambito on how he incorporated DLCO into his cardiac practice. We're going to learn about similar symptoms of heart failure and COPD. We're going to discuss the clinical significance of DLCO testing in these heart failure patients. And we're also going to watch a live demonstration of a DLCO test on the EZ1 Pro device, just so you guys can see how fast and easy it really can be.
Absolutely.
All right. Without further ado.
Hello, Dr. Zambito.
Hello.
How are you? Oh, thanks for jumping on. There we go. There we are.
My pleasure.
Can you hear us okay?
Yes.
Okay, perfect. I'm going to go ahead and discuss with you a little bit more in depth about using the EZ1 Pro lab, especially DLCO, in your practice. So I'm going to ask you just a few questions really quickly as soon as I can see the screen. There we go. Our first question for you is, what was the reason you decided to add DLCO testing to your practice?
Why I decided to add both pulmonary function and DLCO was to deal with the patient's complaints of dyspnea, because this is a pulmonary symptom, and I thought it was very important for me to give them an idea at the end of their diagnostic testing. How much component was cardiac? Do you have an undiagnosed pulmonary disease, which you should follow up? I just felt like it wasn't enough to assess someone's dyspnea using echocardiograms. It sort of added another level, which I think enhances the diagnosis at the end of the day.
Absolutely. And I know when we had spoken before, talking about DLCO and again with COPD and emphysema, we also wanted to know where have you seen DLCO impact those cardiac patients the most when you use this with your heart failure patients?
So the biggest impact is on the heart failure population because there's a lot of good evidence out there that use DLCO as part of our diagnostic following the development of heart failure. There are a variety of ways to use it. I mean, one, you can actually follow someone's worsening state. You can follow someone who was hypervolemic and became bulimic. You'll notice that a lot of times DLCO things change, one of the most sensitive markers. I've also found that patients with very severe fluid overload, they get a restricted, certainly that's someone who's obviously in decompensated heart failure. More useful was following DLCO levels patients with chronic stable heart failure after adjusting their medical therapy, and we use it for also for adjustment of medical therapy. It is a portion of the of lung water. Yeah, we've used it to medical therapy to give them data. We've used it to confirm.
Might have lost you a little bit, Dr. Zambito. I don't know if your connection.
Okay.
There you go. Yeah, there you are.
Okay.
So with that, I know.
So,
absolutely. Can you hear me still?
Yes.
Okay, perfect. And I know you talked about dyspnea as being one of the symptoms that you're using for an indication for DLCO. Are there other symptoms you're also looking at when you decide that DLCO might be something that would be useful with that patient in your office?
Right. Well, yes. I didn't want to I didn't want to be so narrow in my diagnostic spectrum. So, yes, certainly we use DLCO when we diagnose patients with obstructive diseases. We do DLCO testing and PFTs for not just for dyspnea, maybe exertional intolerance, some cough, like I mentioned, both types of heart failure. Sometimes we also have patients with known COPD or COPD diagnosed and work together with their pulmonologist to sort of offer, I know, guidance, which sometimes leads to change in therapy or referral for additional evaluation.
Absolutely, absolutely. And when it comes to adding a test such as DLC or adding a device like the EZ1 Pro, how has that worked in your workflow, let's say for your nurses that are in your office? How do you incorporate that? Do you have the patients tested when they come in? Is there a certain day a week that you use to do PFT testing?
Generally, what we try to do, since we're a diagnostic center, so we do a variety of testing here. We do try to have a schedule for elective PFT and DLCO testing. So it is given on certain days of the week. We have the ability to do it at any time as well, though. Sometimes there'll be walk-ins, sometimes there'll be somebody with decompensated heart failure or something that we'd like to evaluate right now. So the system is very portable. It does not take up a lot of space. It does not require a lot of staff to manage. We really could do it at any time, but most of our elective tests are done on a specific days of the week.
Absolutely, because I think that's something when incorporating PFTs into outpatient scenarios, we're learning how to put that into a workflow that works for not only you and the patient, but also for your staff. So they're not, doing a lot of testing back to back, but obviously it's nice because of its portability and ease of use. If you need something, like you said, immediately, it's there and able to use and ready to go. And that kind of leads us into our last question is the features on the device on the EZ1 Pro Lab that have really helped you when, like you said, when you have a patient who needs something immediate, what features and, to help you get that diagnosis you're looking for and then, properly treat that patient. But what are those features on the device that have really helped you and your staff be able to use that?
Yeah, no, the features on the device, I mean, I have not seen another device as full featured. With the Pro Lab, for example, I mean, you can do simple spirometry and DLCO, which is very easy with your single breath holding method.
Yes.
And you can do all that, and at the other end of the spectrum, if you wanted to do the nitrogen washout to get an actual functional residual capacity and residual volume. I don't use it a tremendous amount, but there are times when the values don't really correlate. The DLCO does calculate those volumes for you based on the single breath, but sometimes we use the multiple breath testing to confirm. It's just great to have that option. I haven't seen a portable system that performs something like that. I mean, usually we're talking about something that requires an entire room that performs something like that.
Exactly. And
that's
allows for warm up.
And that's one of the best features, just how versatile it is. It's great software as well. Like you can choose whichever of the common algorithms that you would like to use for both DLCO and lung volumes. You can sort of change it on the fly. You can adjust it for patients' hemoglobin levels when you're doing DLCO. And one of my favorite things is the fact that you can highlight the abnormal values in a different color.
Absolutely.
And I found that a lot of PFT reports are just black and white, and there's so much data there. There's a lot of numbers on those reports, and I really think it's helpful for your referring to be able to call attention to something that might be abnormal. and it's very nice that you're able to put that in red. The report, it also takes you through how the computer came to that particular diagnosis, whether it's obstructive, mixed, restrictive. It's a very cool flow chart that I'm sure a lot of the pulmonary folks are familiar with, but it's nice that you incorporate that into the software.
Yes, and we talked a little bit about that in this presentation. You know, another nice feature that is easy to use, especially in cardiac offices, is the trending. So when you are watching that DLCO and spirometry and the FRC and the RV, you are able to make a trending report. So there are nice features that are easy to show, especially on your report if you want to see previous DLCOs and how is that DLCO comparing to where it was 6 months ago. So, but you know, we are so appreciative that you were able to jump on with us on your week off. So, and we were going to open it up, and I know the sound got a little in and out in the beginning of our conversation. But if there's any questions that either anyone online would like to ask Dr. Zambito, he is here. But we can also, if you have questions that come up later, we can obviously ask your questions to him later to follow up with. So, but Dr. Zambito, we thank you so much for coming on and talking to us today about this. And with it being Cardiology Month, we knew the guy to call. So, but thank you and enjoy your vacation. So,
thank you.
Absolutely. So I'll just keep it open here for just a second. I have that question and answer bar brought up. So just real quickly, and again, if you guys think of something later, we can absolutely reach out later to get those answers. But if you guys have any quick questions for him before we let him get back to vacation, go ahead and just type those in now. We'll give you guys just a second. And then if nothing comes up, we'll just go ahead and move on. All right, I'm going to go ahead and close that out. All right, so we're going to go ahead and move on with the rest of the presentation. I'm just going to open by giving you guys just a few COPD and heart failure statistics. COPD affects about 1/3 of all patients with heart failure. Women who have COPD and heart failure actually have a 15% higher risk of death than men with the same condition. And also in patients with heart failure, COPD was significantly associated with mortality and hospitalization.
Those are real startling.
Yeah, it's kind of scary statistics
when you see it printed like that. And again, this also touches just back to what Dr. Zambito was talking about when it comes to those symptoms that are similar for COPD and then similar for heart failure. And for those of us RTs or who's on this call that's worked with these patients, you know these symptoms. And wheezing, is it cardiac fluid versus bronchospasm? Is it cough, exertional dyspnea or shortness of breath with activity, fatigue, decreased activity tolerance, anxiety and depression? The initial exacerbation treatment pathways are often very similar. Again, for those of us that are RTs, we know those well. But again, it just gives the ability to show how DLCO can play a factor into, is it COPD, is it heart failure, is it both?
Right. So we all know that smoking is a major risk factor in both heart failure and COPD. So it's really not surprising that these two conditions can frequently coexist within the same patient. There's a growing body of evidence that's suggesting that pulmonary function testing might provide information that is useful to the best management of these patients. Evidence is also suggesting that the use of pulmonary function testing may provide independent prognostic information in these heart failure patients who have with or without pulmonary disorders and can help guide those therapeutic decisions.
Much like what Dr. Zambito touched on with those patients with heart failure. So we just wanted to also just do a quick little synopsis of what DLCO is for some of you who may not be as familiar with it. DLCO is a clinically useful test that provides a quantitative we practiced that today, quantitative measure of gas transfer from the lungs to the blood, complementing spirometry in the evaluation and management of patients with respiratory or cardiac diseases. So again, the way I explain it when I'm training offices is how well, when that patient takes oxygen into their lungs, does it go to the alveoli and get diffused to the bloodstream or to the hemoglobin to give our body oxygenated blood? We really want to know, how is that working for the COPD patient and how is that working for the heart failure?
As you guys can see there, I know it's a little bit small on your screen, but we took from a couple of different papers, really focusing in on DLCO and its importance and how it can be useful in cardiology. So when you go back on this presentation, absolutely go into those links and read through those papers. There's just such a wealth of information in there. We just kind of wanted to highlight some of the biggest takeaways, but we wanted to give that to you all as a reference as well. So why DLCO testing? DLCO offers clinically important information beyond that of what basic spirometry and radiology could give you, and should be considered in characterizing and managing these COPD patients. In patients with pulmonary hypertension, with heart failure, with a low ejection fraction, a DLCO that is low is strongly associated with mortality. DLCO is one of the best correlates of emphysema in COPD. And also a lower percent predicted DLCO is associated with increased COPD morbidity.
It's a big factor. Right. So what we wanted to do today is, for those of you who are not familiar with the Easy One Pro, we wanted to give you a live demonstration of our device and how easy, how simple, I should say, the DLCO test is on here, much like what Dr. Zambito spoke about. So we are going to come over to the other side and shuffle just a little bit here. Jamie's going to be our patient, and what we're going to do is just go straight into a DLCO maneuver. So Jamie, I'm going to have you keep your feet on the floor, sit nice and tall for me, and go ahead and put your nose clip on. With the Easy One Pro, we simply connect the two pieces together, and we won't do a full demonstration for you, but Jamie, I'm going to have you hold the purple hand sensor, wrap your mouth tightly around that mouthpiece, and just begin tidal breathing for me. So what Jamie's going to do is do 4 tidal breaths. So we're just going to have the patient breathe in and out nice and easy. Go ahead, Jamie, and keep breathing normal. And then I'm going to have you, on your next exhale, I'm going to have you blow all your air out. Keep exhaling. Keep going. Keep going. The device will detect when she's out of breath. Keep going. Keep going. And then she's going to inhale over that horizontal dotted vital capacity line and hold her breath. Keep holding. Keep holding. You can see the screen is very interactive with the tech and the patient, and fully exhale. Now we do 2 tests 4 minutes apart, but we won't bore you guys with that today. But we did want to show you how simple that 10-second breath hold is for the DLCO test. Thank you, Jamie.
Oh, you're very welcome. Back over here.
Adjust ourselves here.
All right. Moving right along.
So again, to go over the features of the Easy One Pro, we wanted to really point out the portability and the compact size of it. As you can see, it's 1 square foot. We do use a DLCO tank. We use a helium mixture, but it is something that can be easily set up on a desk or on this cart pushed to bedside. It's simple and easy to use with intuitive user interface, which you guys were able to see. It walks the tech through exactly what to do with the patient, but at the same time, the patient can see what's happening and can see that countdown. It easily and accurately diagnoses using the ATS-ERS interpretation tree, which Dr. Zambito touched about. And it's something that can be removed from the report, but we do use it as an indication to help the diagnosis and interpretation. There's no warm-up time. Again, that was something we talked about. It is, if you have a patient who needs a DLCO, you are ready and willing to go ahead and get that done right away. And we have a true flow software that allows the automatic calibration to happen, which is it's also a nice feature to have, that there is no lengthy calibration procedures that need to happen with a true check and true flow technology.
So what are the key takeaways from today? I know it's been a lot of information, but we want you all to have a better understanding of the risks associated with COPD and heart failure and how they can relate to one another. Understanding the significance and the clinical impact that DLCO testing can have, and also just working through new ways to incorporate DLCO testing into your practice. So again, we want to thank you guys so much for joining us. Thank you, Dr. Zambito.
Yes.
You guys can always visit our website at nddmed.com for links to these webinars, upcoming topics, those research documents. All of that is available right there on the website at your fingertips. And then again, you will be getting that follow-up email from us here at NDD with our contact information and a recording of this presentation. So I'm going to go ahead and open up that question and answer bar again. absolutely feel free to ask us anything you guys would like to know while we're on. And then again, of course, if something pops up later, don't hesitate to reach out then too.
And also for those of you who may not be using our device at this time, you can also always contact Jamie and I to set up a demonstration.
Oh yeah,
a rep with you
absolutely.
in your area that can come show you the Easy One Pro DLCO testing.
Awesome. I'm not seeing any questions right now. We'll give everybody just another second here to get anything typed in that you need addressed. But again, we just want to thank you guys, and we want to be able to partner with you guys just to be able to provide that early access and early diagnosis for your patients. And we hope that everybody was able to get something really informative out of today.
This will be emailed to you if you registered for this, and you'll be able to play it back and hear it as well. And
Right.
I also have Dr. Zambito's answers to those questions.
Yes.
So if it was a little in and out with the volume, we'll be able to send those out as well. So but definitely, Mary, it will be there shortly. Give us till probably the end of the day or tomorrow morning. This will be up on our website and also emailed to you. Yeah, so hey David. Yeah, so we didn't touch too much on amiodarone testing, but yes, DLCO is definitely useful in those patients. We know that there's a recommendation by the amiodarone drug itself that patients should be tested prior to be putting on amiodarone and thereafter following up, especially if the patient starts having symptoms of shortness of breath or dyspnea with exertion is definitely indications. I don't know if Dr. Zambito is still on or not.
I was,
Do you want to add anything on that, Dr. Zambito, with amiodarone?
Sure. No, I was responding to David as well, but yeah, just to everyone, we didn't talk about it, but this is one of the reasons I use DLCO on all of my patients in amiodarone to establish a baseline, and then the data after that is a little bit unclear, but certainly anytime that there are suggestive symptoms, we'll reevaluate them. What I've seen, though, since we do periodically reevaluate, what I've seen is that most of the time the DLCO is the first thing to change, and we have discontinued the medication for people that have had persistent changes that over time, basically, it wasn't just a sort of a fluke. It was an actual decrease in DLCO. Yeah, so we do, and I don't think I have seen any of the other features related to lung volumes to the spirometry with amiodarone, because generally these are very late findings. So I would imagine that most of us would stop the medication at the first onset of suggestive symptoms, especially if there was a drop in DLCO from the baseline.
Okay, perfect. And absolutely. So with amiodarone, obviously DLCO plays an important factor and should be done pre if available and post. I think there's another question. One came in that is asking, doing spirometry before DLCO. We do train that you do either a flow volume loop or an FVC prior to DLCO. We just didn't do it on this video. Right. But yes, we do teach you that. It is important because that vital capacity line, that dotted line on your DLCO screen is placed on the screen because of your FVC, your spirometry. So yes, definitely do spirometry before the DLCO, or it will just use the predicted for that patient's spirometry is not done. So to get your most accurate DLCO, you obviously want to do a spirometry test. Let's see, hold on 1 second. Okay. Yes, can you speak on regarding trending capabilities of Easy One Pro? Absolutely. So we have the ability for you to choose multiple parameters that you would like to trend. So maybe for a cardiology office, like Dr. Zambito spoke about, an FVC, a DLCO, an FRC, an RV. Maybe those are 4 parameters that you would like to trend. We can absolutely do that, and it can come on the bottom of the report for every patient. So if a patient had come to see Dr. Zambito 6 months ago, he wanted to trend those certain parameters, we can absolutely do that. Mm-hmm. So it's a nice feature to add. So I'm getting questions that are coming through my watch faster. They're coming through through here. So let's see if I'm forgetting anything else. If there's not any other questions, if there's something that we can help you with, we would absolutely love to answer any questions. NDD, we will be at ACC this year at March in Chicago, so please come see us. We're going to be offering DLCO testing, so definitely feel free to come see us at our booth because we'd love to see everybody. What predictors do you use? On our device, the system default is set for Miller, but you can, I know GLI is a topic right now that people are using for DLCO as well, but you can choose from wherever your institution would prefers to be. The DLCO cannot be billed as a standalone test. It must be billed with pre and post bronchodilator or spirometry. Absolutely. So when we go out and train an office that's going to be using this, we definitely say do your spirometry, bill that code, and your DLCO as well. So yes, thank you, Roy. Absolutely, we do that. Right. And any other questions we can help answer, or while we have Dr. Zambito on the phone? This is fun. This is the most questions we can. I like it. If you like our shirts, Jamie makes them.
I'm not making any more.
We would for our customers. We asked you would. So, but we really appreciate everyone for jumping on here. And honestly, anything we can do to help, we'd love to reach out to NDD. Dr. Zambito, thank you again for coming on your time off. We really appreciate you not only being a friend to us, but doing this with us.
My pleasure. Take care.
Yeah, no problem. Oh, hold on. Is there
one more?
Oh, okay. Maybe it says, like I said, we're getting it. We have multiple lists.
Places.
My watch just froze. Is there a relationship between DLCO values and mortality? Those papers that Jamie posted, when it comes to using, especially for pulmonary or heart failure with low ejection fraction, there's definitely a correlation with that. But on those papers, you can definitely, those links are, grab those. But yes, there is, and especially with COPD, DLCO is the best predictor of patient mortality. So, and we talked about this today with our company, and DLCO was always a test that was done. You did spirometry or you did full function PFTs. And we really at NED believe that taking spirometry and DLCO together really does give you much more information right there when the patient's in front of you. So yes, DLCO, the COPD gene paper that was just published in Chest in December definitely talks about that. Right? Any of let's see, hold on. Dr. Zambito, are you there?
Yes.
I have a question that says, what are the expected changes in DLCO when you have a CHF fluid overload?
So the changes which can happen acutely, so even in acute pulmonary edema, the DLCO is the first thing which will drop. And if severe enough, you'll also get restrictive lung disease patterns. So you will get basically an increased FEV-FVC ratio, and you will get a decreased total lung capacity. But the earliest finding, I would say, is a decrease in DLCO.
Yeah, absolutely. That's what we, really have, when we train offices, is to watch for that low DLCO. Because sometimes spirometry even shows normal, and then you have a low DLCO. And what does that mean? Is it congestive heart failure? Is it the beginning stages of interstitial lung disease or early stage emphysema?
Well, it's important to establish a baseline in your heart failure patients as well. Because depending on the severity of their heart failure, and they may always show a pulmonary vascular disease pattern with the impaired DLCO, especially those that have pulmonary hypertension. So it's important to establish a baseline.
Absolutely. And, with the device, a calibration question did come up. You are able to check calibration on our device. Just so we follow ATS guidelines they recommend calibration checks. So you can use a 3-liter cal check, but we also have a feature called True Check, where our device does a 5-point cal check before every single DLCO. So what you couldn't hear, what we showed you, we did kind of a cheat. We went to our software, but what our device does is it checks the ambient air and the test gas. And then again, at the end of the test, before every single DLCO, it takes about 15 seconds. So that way you know as the RT that your device is working, the gases are reading correctly, and there's no drift. And the nice part is it does it before every single test, and that's called our true check technology. Sorry. And yes, the Easy One Pro, lends itself very well to point of care testing, obviously, because it's like Dr. Zambito said, if he is someone who walks in and needs testing immediately, that's something you can do right away. And you not have to send them to the PFT lab, because we know sometimes patients don't have a ride. Maybe they're living too far away. We have a lot of rural hospitals that use us. So definitely having that point of care, patient's there, patient has symptoms, doctor wants answers, it's something that can be done right away.
Right. And so many PFT labs, especially in these rural areas, if there's one point of care access hospital, you have patients that could be waiting 3 or 4 months before time in the PFT lab could be set up.
Sorry, guys, that I'm trying to read your questions on my watch. Oh, technology. But thank you guys again. I know we're kind of gone over our time by 3 minutes, but we enjoyed doing this. We'll be following up with another great topic next month.
Right, talking more about DLCO next month and just the benefit of adding it to your practice. So we're excited to be able just to kind of expand on this talk even more.
So thank you all very much for jumping on, and please continue sending us those questions.
Yeah, absolutely. All right, guys, have a fantastic afternoon. Enjoy the day, and we'll see you all next month.